Welcome, everyone. Thank you so much for joining us. We will get started in a second as people come and join the webinar, but this is the Lessons from the Learning Initiative Promising Engagement Practices webinar series for this summer. We're so excited that you guys are joining us. We have an amazing group of hospitals presenting with us today, so I'm really excited that you are here. We are going to be talking about doula engagement and patient advocacy. So we are really happy you guys are here. If you can double check that you are muted. We will have a Q&A function enabled. So if you have questions throughout the webinar, you're more than welcome to put them in the Q&A. We'll be answering them throughout the webinar, but we'll prioritize Q&A at the end. The chat function probably doesn't work. I don't believe we have that enabled, but if you do have any specific questions or want to reach out, use the Q&A function, or you can email us at the end of the webinar. I'll go ahead and get started. So again, thank you guys so much for coming. You should all be muted upon entry, but you can utilize the Q&A function. We'll be doing our best to answer those throughout the series. Please don't copy the slides. If you'd like to reach out and get any more specifics or reach out to those hospitals, you can do so at the end. And send us your feedback. We are always looking for recommendations for improving future webinars. We hope to continue to share all of the learnings and education that we have available to us. The slides and recordings will be posted within the next 48 hours on cmqccs.org underneath Education, Research, and Webinars. And this is our agenda for today. I will introduce the Learning Initiative, which is the CMQCC collaborative that we have that we'll be discussing today. And then we'll go through some hospital presentations. We have 4 hospital groups represented today. I'm so excited for you guys to hear from them: Community Regional Medical Center, Kaiser Oakland and Kaiser San Leandro, and Kaiser South Sacramento. And then we'll have some time for questions and answers. So as a brief introduction to the Learning Initiative, let me give my introduction. My name is Savannah Gray. I am the Clinical Program Manager with CMQCC, and I have the honor of getting to be the manager for this program. So I'm really excited to share a little bit more about what we do. The full name of the program is the Learning Initiative to Support Vaginal Birth Through an Equity Lens, or what we like to call it as the LI. It is a CMQCC Quality Improvement Initiative. It's funded currently by the CDC, and we have funding through 2027. So we are about at that midway point, which is why we are super excited to highlight some of the lessons that we've learned so far. The Learning Initiative is a 5-cohort program. Each cohort group is about 18 months long. So this month, we'll be talking about some of our hospitals from round 2, which is exciting. This program is built on the successes and learnings that we've had from 2 collaboratives, specifically the Supporting Vaginal Birth Collaborative, which was run between 2017 and 2019, and the Pilot Birth Equity Collaborative, which started in 2019 as well. These 2 programs really helped reinforce a lot of the learnings around reducing NTSV and promoting vaginal birth, and how we look at that with an equity lens, how we are prioritizing different populations in the state of California at large. Some of the specific goals of the program include focusing on reducing the disparity gap that does exist in low-risk cesareans, hoping that the goal is to reduce the rate of cesareans among all patient groups below the healthy people 2030 rate of 23.6. That goal kind of breaks down into looking at the racial and ethnic differences in NTSV cesarean rates, increasing the participation of hospitals in this program for those that have high NTSV rates among different population groups, increasing patient and community awareness around the existing disparities, and increasing the number of hospitals that are engaging with their patients, engaging with their communities to help inform the adoption of equitable care practices. So those are our goals for the Learning Initiative. This is what the program and curriculum currently looks like. We have monthly coaching that provides education and builds capacity among health workforce for quality improvement fundamentals, including PDSA cycling, developing driver diagrams, looking at your different baseline assessments. We talk about implementation science with our wonderful implementation science advisor, Melissa Rosenstein. We talk about principles of respectful maternity care. And we provide a lot of technical assistance in leveraging the different tools that CMQCC has, including the Maternal Data Center and the Hospital Action Guide for Respectful and Equity-Centered Obstetric Care. We do also have these quarterly webinars on health equity and cesarean rate reduction tools. You can find those webinars on cmqcc.org. They're called our Let's Talk Perinatal Equity webinar series. the really intent behind this, this Lessons from the Learning Initiative webinar is to highlight that this is a long-term effort to shift culture that supports and promotes and embodies respectful care. These are the building blocks of culture change, which we talked about last month, that takes testing and iteration to figure out what is going to build your own culture in your unit, what is going to make the biggest impact with your patients, with your communities. So that's why we are highlighting all of these different best practices that hospitals are doing to see what might work for you in your facility, whether in California or different states around the country, to figure out how you can make the biggest impact and improve your patient care. So today's presenters, we have Community Regional Medical Center, which is located in Fresno, California. We've got Kaiser Oakland and Kaiser San Leandro in both of their respective cities, and then Kaiser South Sacramento as well. We've got wonderful team members here, super excited for you guys to meet them. So without further ado, I will go ahead and pass off to Community Regional Medical Center to share their presentation and what they're working on. Hi, Sarah. Hi, Chelsea.
Hi.
Hello. Go ahead and take it away.
Okay. Well, my name is Sarah Putman, and I'm the Director of Women and Newborn Services at Community Regional Medical Center. And this is Chelsea. Would you like to introduce yourself?
Sure. Hi, everyone. My name is Chelsea Evasion. I am the Project Manager of Community Benefit and Outreach for Community Health System, which includes Community Regional. Excited to be here today.
So a little bit about our facility. We are actually, like Chelsea said, we're part of a health system that has actually 4 acute care facilities in the Central Valley of Fresno. The Community Regional Medical Center campus does about 4,500 deliveries a year, and our sister facility does about 4,000. So we're quite busy. We are pleased to be advanced certification in perinatal care. That is something we have learned from and continue to grow with, and really enjoy that relationship with the Joint Commission. We also see quite a few high-risk patients as we have maternal transfers coming from all over this region, which serves a little over 2 million patients. And we also have a level 3 NICU. What we're going to talk about today is our partnership that we established with the Black Wellness and Prosperity Center. Unfortunately, Shantae couldn't be here today, but she is an inspiration for any of those who meet her. She founded this group in 2019, and she really started the connection with Chelsea and I. I had professionally known Shantae, and we were both very, very interested in making a difference in the community. And you'll see on the next slide where we really talked about what we could do to make a difference. And really this partnership that we built between the Black Wellness and Prosperity Center with Community Regional was to help with their doula training program. So they actually trained the doulas and then brought them to our hospital for their observations. I don't know, Chelsea, you'll chime in if there's anything.
Absolutely.
Okay.
I don't want to interrupt your.
Okay.
One thing that, Sarah started to really talk about was what Community Regional's role is within our health system, but also within the larger region. It's important to note that CRMC is the safety net provider for this Central Valley area. And so the patient population looks a little bit different for CRMC than maybe for some of our neighboring facilities. We have a very, very high Medicaid and Medicare population, with about 84% of our patients utilizing some form of government insurance. And so that is really kind of part of the underlying cause to how we realized that the working in the doula space with BWPC would kind of get started. So anybody who's not familiar with how the doula partnership works now is once Medicaid, Medi-Cal had really decided that doula services were going to be an opportunity for coverage. We started having a little bit more conversations with Shantae about what that would look like and how we could do that. The Central Valley is actually probably not very unique, but it is interesting in the sense that we have very, 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 very few doulas that exist within this region in the first place. And we have very, very, very few people who know what a doula is. And so we had sort of this situation where we had this coverage that was coming and we were excited about that. But we didn't really know what that would look like. We didn't know where these doulas would be coming from, how would they interact in our facilities, what would their training and preparation look like? And because they're not super common within our facilities, what would that be like for the care team? And that's really where Sarah came in and was able to start moving that forward.
Yeah, it was very, we did spend many hours, times meeting and discussing what we thought needed to be our priorities. But defining the role of what the doula trainee would be doing and how they would be functioning on the unit was somewhere in between what like a nursing student would be and a volunteer. And so we realized quite quickly we were creating something relatively new. We actually likened it to some of our EMS paramedics that come through labor and delivery, with the goal of observing essentially as many deliveries as they can. So not as hands-on as a nursing student would be and more of an observer role, but a little more than what a traditional volunteer would be. So with that being said, we said, well, how are we going to onboard these people? And what was so neat is we walked through all these steps together with Shantae and her team. So it was just such an interesting lens because when you work in a hospital and that's your world. I mean, I was an L&D nurse for 25 years at the bedside before I went into leadership. So it's my lens on things was so different than what Shantae, who is a doula and a community leader, and her team was. So we really had to start from the beginning. How would we onboard these people? How do we get nurses and providers ready to embrace these doulas as part of the healthcare team? Because many of them had not had experiences with doulas. So we spent a considerable amount of time on that. And then we even talked about what is it going to look like when the doula trainee is on the unit and that patient relationship, and how do we gain consent from the patient? How do we help the patient understand what is a doula and why are they here for training, and why are we as an organization committed to making doulas available and creating a greater resource pool. And then we even went to the point where we got Shantae and her group that came in and they pretended like they were a doula trainee. And I greeted them like one of my L&D supervisors, and we walked through the unit and we went into a birthing room and we showed them, this is where you're going to put your purse, this is where you're going to sit, this is where you're going to stand. And but the day, basically what a day in a life of a trainee is going to look like. So it was time consuming, but very well worth it.
Absolutely. And as Sarah just sort of highlighted, there were a lot of moving parts in the process of getting this up and running and kind of going. And what really started as an exciting hypothetical idea took a lot of time and a lot of energy and a lot of resources and a lot of coordination between a lot of different people. And that is really one of the things I think that we can't understate enough is how much all of this work really, really required developing a relationship, a trusted, secure relationship before we could develop this partnership. And that was really sort of the starting point for us. And I know in a little bit, we'll kind of go through what that looked like for our specific situation. But really taking all of these little steps was so beneficial and making our care teams more aware of what they should be expecting from the situation, and also making sure that our doula trainees felt really welcomed and knew that we wanted them there and that they were invited. And this was not just a leadership decision that was, well, we're going to do this, and the unit was not on board. And so really taking all of those little steps, I think, was critical in how all of this played out. So go ahead, Sarah. Do you want to cover how we kind of got here?
Sure. Well, Shantae and I had known each other through some other work experiences, but she reached out to me with just some. We knew we wanted to make a difference. We knew we were both in critical roles, and leaning in the right direction would be beneficial for the whole community. But we started out with listening to Black patient experiences, because I knew as a leader that was something I was very interested in knowing. So we started out with that, and then we I know Chelsea even went to some community listening sessions where other hospitals were involved and focus groups. And then the conversations around doulas really picked up. Like Chelsea had said, is when Medi-Cal announced that they were going to start covering doula services, it was kind of like this. Since we had already started this relationship, it was just kind of the icing on the cake to have this wonderful opportunity open up that needed our energy behind it. And one of the things that we had already started doing is looking at our birth equity data through CMQCC. This is right when they first started those dashboards. And so we had really said, we've never looked at anything from a race and ethnicity lens. Let's see what CMQCC has in store for us, because we knew that was part of the focus of our advanced certification in perinatal care. So that really was that other driving force that got us headed in this direction as well.
Absolutely. So if we go to the next slide, you'll see a little bit of a timeline for what this looked like. Like Sarah mentioned, she had a wonderful relationship with Shantae prior to BWPC even existing. But when that was created in 2019, that relationship sort of continued, and Sarah did a lot of outreach and connection with Shantae to get a better understanding of what the Black patient experience really was looking like and where we could grow and improve. I sort of entered the picture just at the beginning of 2022. And when I came on community, there had been some additional conversations surrounding a relationship with the Black Wellness and Prosperity Center, but it had shifted a little bit. And I think all of us would say that that relationship had moments of tension. It was not always a super smooth and easy dynamic. And a lot of that really came from all of us having different lenses and different experiences and concerns, and not really knowing or understanding what that looked like from the other perspective. And so we decided that we were going to try and improve that relationship. And that really looked like a lot of conversations and meetings between myself, Sarah, and Shantae, and just talking to each other, hearing each other, and taking the time to really explain limitations and desires on both sides of the spectrum. And so then in about 2022, we had a community listening session in which Sarah and I, as well as other hospitals in the area, connected to hear about what the Black patient experience was delivering in local facilities here. And that was both wonderful and also really scary to do. It was very uncertain and unknown, and you have to have that information to be able to help, but you don't always have, you don't really know what the environment's going to look like. And for us, that was a phenomenal experience. All of the kudos to Shantae, because she did a wonderful job managing that. And we just kind of were able to continue to grow and build a true relationship. And then toward the end of 2022, as there was more information coming out about Medicaid coverage, that's when we really shifted the conversation to talking about doula care specifically. We were fortunate, our senior leaders got on board very, very quickly with that process, and we're excited about it, but nobody really knew what that was going to look like. And that's where we started diving into the development, contract design, how everything would be structured. And that was really a collaborative experience, not just in contracts, but how was BWPC going to be training their doulas? And so we were very fortunate that our care teams had a very hands-on role in what their curriculum looked like. And then we are very excited to have been able to welcome the first cohort in 2024. That's right.
Yeah, actually October 23
Oh,
is
there
when
you
they
go,
first
October
started. So
yes, all the years are blurring together.
Yeah.
So that is, that's sort of how we got here. And that's sort of what our timeline has looked like.
And Chelsea mentioned how many people we needed to get involved, and certainly the leadership from my areas, but the executive leadership, Chelsea's area, which is community engagement and benefit, communications and public affairs. We had legal look at this, risk management, of course, human resources, a huge component. Then as well, contracting and volunteer services. And I think our last, I think we've mentioned some of this already. Facilitators is that we already had some data and a good relationship, but building trust did take time, and improving the understanding of the doula role. And then having Chelsea's role was huge in making this work. And then we still face a challenge with the doula resources in town. So we are now partnering with Fresno County Public Health. We're really thrilled that they're going to start doing some training as well and bringing them into the hospital with the same concept. Also, BWPC has shared the contract we made with other facilities so that they can get other hospitals in the community involved as well. And these are just some of the events that we've been involved with Shantae. So it's just so wonderful to get out there and say, what is a doula? How can we help you? And I think that might be it.
I think so.
And here's one of our trainees. They had their cool pink scrubs, and it said Black Wellness and Prosperity Center. It was wonderful. So hope this helps.
Awesome. Thank you guys so much. I absolutely love this example, especially as it started out with something you were just trying to learn experiences and explore that relationship. And you became this influential partner in the county to help other hospitals do this and make this partnership. So thank you so much for bringing the highlights. If you all have any questions for Sarah or Chelsea, please feel free to put them in the Q&A and they can fill in some blanks or some gaps for you. Kaiser Oakland and Kaiser San Leandro, I'll have you guys next. We've got Emily, Christine, Anya, perfect. Awesome, guys. Thank you so much for being here. We're excited to showcase a little bit more about what doula engagement and partnership has looked like for you all.
Hi, everyone. Thank you for having us. We're a big team as listed on this page, but just a few of us are going to be speaking, but a few more of us are here and are happy to answer questions as well. Next slide. So we wanted to start really quickly with the why, and the why isn't so much for this audience who may already know it, but the why was how we started in terms of thinking of where we're headed with all this and how do we frame it for our audiences. We know that there's a legislative mandate. First, it was the expansion of Medicaid, and then in 2025 to private insurance. Doulas help to determine where patients go to give birth, and this can be a big driver for how you approach this within your own hospital or your own environment in terms of selling the why. Staff satisfaction was another big thing that we brainstormed, meaning that in order for staff to integrate doulas and to understand all the benefits to us as a system, they needed to know what a doula is, what they do, and they needed to be able to provide feedback to us, and we needed to be able to provide feedback to them to sort of help everybody feel whole with this idea and to feel like their voices are heard bi-directionally. And then the why was also the benefits of doula care, which Savannah mentioned at the beginning, right? We're looking to improve our NTSB C-section rates. We want our patients to be supported. We want to address the major disparities in birth. And doulas are shown to do all those things. Next slide.
So our steps really, I think, just like the previous team presenting, I think it's important to acknowledge this really was a multi-year process, and that relationship building was really the key to the beginning here. So we'll explore some of these a little bit more in detail in the next few slides, but the start is, just trying to build connections with community doulas, and you might need to go out and find some of the community events. We're in the Bay Area, so we have a lot of very active doula groups in our region. So just looking at where you are and what's going on around you, you might be surprised at how much activity there is. So attending events just as yourself, and introducing yourself, mixing and mingling, and you might be surprised at how much enthusiasm there is to partner with you. And if you're not ready to step into a community event, it was it might surprise you to find how many people in your own team there are that already have those connections, are doulas, maybe have a history of being a doula. I was trained as a doula. Anya was trained as a doula. We, have that background. And in our member advisory council, coincidentally or not, there were lots of doulas in our patient advisory council. So they have, they have a motivation as patient advocates, community advocates, and so it makes sense that they would cross into this volunteer position of being patient advisors. And so see where your connections already are. Of course, it was mentioned before, but getting that executive sponsorship, making sure that your leadership is not being left behind and not aware of what the value is. I think as Anya went over, it's really easy to share the value of doulas, and I think that the appeal is clear as long as you just make sure that that is something that is clearly articulated. We had a lot of very enthusiastic support from many of our higher up leaders, and that helps to kind of smooth the path when we would run into something that we needed solved. It helps to have people already informed of where the organizational values align with the goals that you are putting forth. And then we called it the Hearts and Minds campaign for the team, preparing to welcome the doulas. And I would often describe this as like trying to get our own house in order first. Like you don't host a party without cleaning up a little bit and, making some plans and making sure that everybody is ready to welcome the guests. So making sure that we're able to welcome the doulas and that all of our team members are really ready to be on the same page with that messaging was really important. And it wasn't overnight. So if you haven't started yet, start today. Um, and then once we had maybe laid some of that groundwork, then you're ready to start planning your event. And so for us, the event has really been kind of a core part of our efforts. And we'll go into a lot more detail about some of the ways that we have hosted some doula integration events. And some of our early projects were we were able to hear what the doulas were asking for and make a move to take action on the things that they were requesting. It was very easy to pick from a few things like creating a welcome letter and creating a feedback survey and setting up communication channels that those were doable for us, and they were high value for the doulas from the feedback that we received from them. Next slide. So identifying your champions of doula integration. Any project that's going to be really new like this, you might need to kind of form a new little group. We found that there were already, some individuals that were very motivated by this. Midwives tend to have a lot of interest in integrating doula care. And so that might be a resource for you. If you don't have midwives at your facility, maybe you have a group that's working on care experience. Maybe you have a group that's working on supporting vaginal birth. We have actually been able to pull interest and take some time from groups that already existed to work on doula integration projects. So that's been very helpful just to kind of identify how many places doula integration crosses into the work that we're already doing and find motivated people to help partner with us. But we did form, we found it was really helpful to form a core group. And then because we are neighboring hospitals in the same system, it made a lot of sense for us to kind of join forces. Oakland and San Leandro are not that far apart by mileage, and doulas really kind of see us as, just one big Kaiser. And so we're all in the neighborhood together, and they might bot back and forth between the two facilities, depending on the needs or location of their different clients. So making sure that when you're identifying your champions, you're not just looking at who might be like organizationally the leader for a project like this, but making sure to include people that really have a passion and interest in something that is potentially a very unique transformative project for the organization. So making sure that someone who is really invested in that listening and community integration piece is part of your group. Because the last point here, including the doula voice in the work is absolutely critical. Something that is like a mantra of mine is like nothing about me without me. That if you are trying to build a partnership with doulas, you really can't do that without doulas as part of the core group directing the work. And so just don't leave the doula voice out of this this project from the beginning. Start with them. Next slide. So the Hearts and Minds campaign for your team, I think that this was both the most time-consuming and ongoing part of the work, but also the most, the key to the success. I think that sometimes we're just like, okay, we have to integrate doulas, check, check, check. Let's see what we can do. It's not going to work like that for something that is so to be honest, very emotional. People have an emotional reaction when you talk about doulas. I think that on our team, we found that some folks were very enthusiastic, and some folks still had a lot of like uncertainty or doubts about it. So it's really integral to start early with your team. And we went to all the meetings and both shared information, not presuming that people know what a doula is or what a doula does. There were a lot of things to clarify that I was surprised that someone who's even worked with several doulas wasn't still really clear about what their function was, what their role was. So providing information, but then also making space to listen to your team so that they can feel heard. If they have concerns, if they have questions, if they have doubts, um, a little bit of listening has really gone a long way to draw out the concerns and address them so that they don't undermine the success of the project. And also, we made a very organized effort to draw out the positive stories and to normalize the sharing of the positive stories about the benefits of doula care. The storytelling is so impactful for changing the way people feel and their receptivity. So emphasizing the positives as much as possible in these group settings. And something that we also found was helpful is to start making a connection as we talk about building partnerships and integrating doulas into our teams. What are the skills that we're already using to communicate with each other? Team steps, concepts about high reliability organization, these professional communication strategies can be, this is already a language that your team understands. And so how can you talk about the ways that we can work with doulas to raise the level of care that we're providing to our patients by integrating our communication strategies we're talking to doulas in similar ways that we're talking to the rest of our team members, sharing feedback, debriefing, things like that. So these are concepts that the team may already understand. And so you might be able to start applying them to the way we work with doulas. It's different than the way we work with family members or patients directly, but more of a professional collaborative type of strategy. So that's a mind shift that you can start to work with your team on early. Next slide. So once you've laid that groundwork, time to plan an event.
So one of the strategies that we have been working on is creating both in-person and virtual events for our care team to really partner with the doulas in our community and really make them feel like they are part of the care team providing care for our birthing families. So these are some of the strategies that we used for planning our in-person doula events. We'll also talk a little bit about the virtual ones. The key pearls are start early, give yourself several months to set up this event. We want to provide an opportunity to build these connections within a friendly environment. We did very intentionally invite representatives from various MCH teams to come to the doula event. So it wasn't just, a handful of us with a kind of a large group of community doulas. We wanted to make sure that we also showed up en masse. And that really showed our commitment to this very intentional integration of doulas. So we had our regional MCH director, we had our OB anesthesia team, we had physicians, we had midwives, we had nurses, social work came, really just to show the doulas that we really committed to making them feel like they were part of our care team. As part of our events, we are working on sharing publicly available data. That was one of the requests from the doula community, was to have more data transparency. And so we're incorporating that into our events. We also wanted to provide a forum for us to give updates on the things that we are working on, whether it's early labor walk or labor support classes, or, we rolled out doula badges or policy changes. This is a great place for us to provide those updates. We did also offer a tour of labor and delivery. And then the most important things that we did were facilitating a listening circle with our doula community, and then had a suggestion box for those that maybe didn't feel comfortable raising their voice in that setting. Next slide. So for the logistics, we did it on a weekend because that was optimal for just people's availability, both for our doulas who may also have another job, as well as for our own team that may be booked in the typical Monday through Friday. And we did it in the afternoon just so that it was easier for parking purposes. We had kind of snacks, drinks, decor, really wanted to create an environment where we could get to know each other first. We stole this. We did this at actually both San Leandro and Oakland events. We wanted to have identifiers that was not just our badges. And so in order for us to identify who was a doula and who was a Kaiser staff member, we had little butterfly stickers or flower stickers. So the butterflies were the doulas, and they're the ones that go from site to site. And the flowers are the Kaiser employees that kind of stay where they're planted. So you could quickly identify who was who. We had a listening session. The really important part of this listening session is that you as a team have to be prepared to hear what they don't like about your facility, right? What issues that they have or bad encounters that they may have had. That is an important part of building this relationship so that they can share what they want to see from us as far as change. And then we can take that, we can answer their questions, and then really use their feedback in order to drive change at our facilities. So again, that first hour was that check-in and mingle. Then we did the listening session. We did include a seated presentation where we were trying to provide some of those updates or share our policies, but we found that for the in-person event, we really needed to leave the most amount of time for the listening circle. And we did designate a facilitator for the listening circle just to kind of keep things on track. Next slide. So this is what it looked like for the San Leandro event. So this was shared pretty widely in doula Facebook groups and things like that. We did have people RSVP or register for the event just so that we could establish an email list as well. And so this is what was done at San Leandro in 2024. So they had 35 attendees. If we go to the next slide, we did a similar thing in Oakland in April of 2025. Same kind of structure. And then we are kind of going to each other's events to support each because we know that the doulas are going between our two sites. Next slide. So these are just some photos. You can see we have our registration table. We were able to give out kind of little goodies. And just, you can see we had a lot of staff that also came and participated, which was excellent. Next slide. Christine, is this you or is this me?
Yeah, this one is, you know, we've kind of explained a lot of the details, so I won't go into any more, but, you know, feel free to borrow our agenda. Can't emphasize enough that the mingling in that casual setting was really amazing and unique opportunity because, of course, most of the times when we are interacting with doulas, it's in the patient's bedside. So we're not really able to have the same kind of conversations. So being sure to give plenty of time for the mingling, you know, trying to get those little icebreaker stickers going, make it a really warm and welcoming atmosphere so that people are not afraid to talk to each other. And then that facilitated listening circle, especially for the in-person event, absolutely key. That was kind of our big lesson learned was small amount of information sharing initially and more listening and getting to know each other.
Go to the next slide. We did want to make sure that we shared data. And so I would recommend reaching out to the maternal data center team. If you want to share data in a more public setting, they can give guidance on how to safely do that. We shared our Cal Hospital Compare data and also walked them through and answered their questions about it as well to kind of build that trust and transparently share while still maintaining appropriate data use. Next slide.
All right. Real quick, these are a few of the additional things that you can consider doing. A welcome letter is a great thing to have on your unit in general. And you can put it together. Mainly it's a way to communicate to the doulas, like, this is where you park, this is where things are, this is how you can provide us with feedback. We created a survey for feedback, that a QR code that doulas could scan and provide us with feedback about their experience. Next slide. These are the circle guidelines. Christine really emphasized the importance of doing a listening circle and how much time it can take. These are guidelines that we borrowed from Transforming White Privilege, which is a class you can take, and they really help with set and setting for this. Next slide. This is our suggestion box piece of form that we had. It was just like a quarter piece of paper. And if folks felt uncomfortable speaking out for any reason or had private things that they wanted to share, this was the way that they could do it. Next slide. So this is an important piece. We also have had virtual events. We have now had 2 of them. Virtual events are shorter format, 90 minutes. We tried 60 minutes, not enough time. 90 minutes is best. You can introduce various members of your hospital team. It's a much better place for information sharing. As we said, that listening circle really is going to be key in those first probably 2 years worth of meet and greets. And the doulas still are interested in information sharing, like information about induction of labor, which is what we shared at this last event. So it's important to have this other format that in which you can do these things. And it's also an opportunity to close the loop on previously shared requests or questions from those in-person events, because we're doing the virtual events quarterly, so they're happening much more frequently. You can also consider bi-directional sharing. So have a doula present to the team and share information that they have in the community. They are full of wisdom and things that we don't necessarily think about. And as always, you want to include time for Q&A. Next slide. So this is some of the feedback that we've gotten in our surveys that has shown the progress we've made. So there was lots of early feedback in the listening circles, one-on-one and emails about all the struggles that the doulas have faced in integrating with the medical system. And then these were some of the kind of encouraging feedback we got as things progressed. And our next steps and steps that we continue to take is sharing this feedback, sharing the changes, sharing the processes with our staff, with our leaders. We're looking for funding sources to help kind of make these events more robust. We're growing our data collection to inform the gaps and opportunities that we still have. And there's plans to integrate a few different things into Health Connect Epic to help us do that. And then we created a feedback loop. We have an email address through which the doulas can reach us. And like we talked about, feedback survey, welcome letter, badges have all been very helpful. Next slide. And these are email addresses for Christine and myself. Feel free to reach out with us with questions.
Wonderful. Thank you guys so much. This is another awesome example, really a great best practice. Super excited that you guys were able to share all of that. Again, if you guys have questions or anything, please feel free to drop in the Q&A for them to answer. And I will move on to Kaiser South Sacramento, our last team. Thank you for being here. Lexi and Spring, I think that's you guys.
Not letting me.
It's not letting our video. Can you?
Oh, let me see if I can get that fixed. Hold on. There we go.
Yeah. Okay. Hello.
Hi,
everyone.
go ahead.
Oh, hold on. Okay. So hello, my name is Lexi Parmer and I'm a staff nurse 3 here at Kaiser South Sacramento.
And I'm Spring Edwards. I'm a staff nurse 4 here, labor and delivery at South Sacramento as well.
And we're going to be talking about our early labor walk. So we go to the next slide. We're going to go into our why. So we're part of our Supporting Vaginal Birth Committee here on our unit. And it came out when we were looking at some data that we were starting to see that we were having early admissions to our hospital. And we did what was an early admission. It would be a definition of someone who is 3 centimeters or less, their bag of water is intact. And so we did things for our patients when they came in for induction, or patients that ended up being admitted even with this early state, to implement support like doing circuits for patients who are admitted. But we wanted to do something to really help support patients to be able to have support in early labor outside. So why we did our walk was to help. We wanted to make sure we weren't increasing our C-section rate. We wanted to work with our patient satisfaction and to not get them admitted early. Go to our next slide.
So the evolution of the labor walk, we really, it truly is a labor of love. We started talking about doing a labor walk in 2018 and initially had a little bit of traction with leadership. And then of course, COVID happened and everything with everybody's world stopped. So we kind of got it put on hold. Then we moved through to that new leadership era, got more people to get buy-in. We were working towards a labor lounge. I think was it Santa Clara or San Leandro that was doing the labor lounge for, we were looking at seeing maybe we could do that for the early labor walk. And then finally, another management shift, and we were actually able to pitch the idea that we could actually have people supporting physiologic birth walk around and do different stations throughout the first floor of the hospital. 2023, it was really about getting everybody brought in. Does the next slide kind of go over? What's our next slide?
Oh,
Yes, so this is basically how we had to justify why we were wanting to get this going, showing that not only were we our admissions to the hospital were ending up higher, but we also our diversity. You can see that there is a difference with who is getting. We have a equity in the lens and stuff.
you can go to our next slide. And this is looking at more, we really wanted to look at our NTSV rate. Our goal is to always have our NTSV rate below 23.6. And when we first started this, we were seeing that our NTSV rate was higher. So this was going to implement to not only lower NTSV rate, but also to look at it, look at this like looking through a lens of equity to see that we were also having a place that would make a safe place for patients to labor in early labor. Go to our next slide.
So what is it? What is the early labor walk? Basically we took, and it's, what is the order of operation? A lot of it had to do with being selected with walking around with risk management, the facilities management. We had to have everybody buy in. We landed on a 8th circuit. All of the different stations have a different function for supporting physiologic birth. It's evidence-based. And they will go through, and each of the activities, it usually is about a 10 to 15 minute, depending on what activity they're doing. And it's supposed to help facilitate either not only the labor process, but kind of if there's 2 friends that we have in mind. I think that's kind of the easiest way to say it. The friend that is the prime, that is not coping in labor, the one that's like, I keeps coming back in, I'm in so much pain, I know that I'm in labor. And then we also have the the mom that's like, I go super fast. And you're like, you're 1 centimeter. She's like, no, but I go fast. This walk kind of gave that opportunity for both of those patients, and also the patients that maybe don't have a space, in the neighborhood to go walk around. Maybe they don't have a household, they can actually have space to safely do these things. So by doing it on the first floor of our hospital, we were actually trying to kind of encompass all of those friends and give that autonomy back to them. So, of course, the buy-in for that was heavy. We created an algorithm, which is the next slide. Lexi can speak on that.
So we created an algorithm because one of the things that we knew was like difficult is we wanted to make sure we had support and buy-in from our hospital, from risk management. We presented this, was able to get meetings with our CNE, our risk management, our manager of our floor. And as we kind of said, one of the struggles of getting it implemented is some of those people change roles every few years because people like to progress with their job. So we had to present it sometimes a few times, but we went back to it and we're really motivated that we wanted to do this project. We came up with this algorithm so that it was safe. These were patients who were triage patients, and then they would meet criteria for discharge. We decided we came up with them having a reactive a reactive NST, stable vital signs. It was agreed upon with the provider that was caring for them and the triage nurse to make a plan, and that the patients would get these options, if they weren't in active labor and they were still in that early labor, that they would be they could be discharged home, or maybe a patient would want to be discharged home with therapeutic rest, or their third option, they could be discharged home with this early labor walk, and an education would be given from the triage nurse about the early labor walk. It was important that we wanted to make sure that the pregnant patient had a support person with them. We also saw that it was really important that our pregnant patient wore a lanyard identifying them to everyone in the hospital that they were on the early labor walk. There was concerns kind of in the beginning of this project that people were concerned that pregnant patients walking around kind of breathing through contractions, that it would make other people really nervous. And sometimes we have a code at our hospital called OB alert, and that's when someone's going to to be having a baby, that sometimes that this might get called, and then staff might be called to a situation that necessarily this patient wasn't in labor. So it was really, we had to do a lot of education with staff around the hospital and security, letting them know that these patients would be walking around. We'd also send the patients with their support person and give them water and a snack. And then they would get a little lanyard that had a QR code on it to show them this early labor walk. And what's really cool is on this lanyard, it also has our phone number. Each slide of the early labor walk has the phone number. So in case the patient does start going into more active labor, or maybe their water breaks, or they start having anything abnormal, that they could call and come back up to see us, and they would be able to say, oh, I'm at station 5, so we would know where to come get them support. The patient would also have the option, if they wanted to, anytime during the early labor walk, if they decided, well, I'm not actually in labor, they could have the option to go home. But what this really created a safe space, again, for patients who didn't maybe have an option because maybe they live far away, or maybe they didn't have an option where to do these movements. And then these movements were also exciting because they could go home and do them at home as well if they did that, or come back in labor. Go to the next slide.
And the next slide, I think, shows our lanyard. That's basically, if lost, found. I kind of looked at it that way, is the idea that it very clearly identifies who's on the walk, and then if for some reason they were unable to articulate what's going on, that somebody could actually give a call and get help for them. What it really is, I think, more than anything, and has been such an amazing thing, is truly to actually see people laboring in the wild. Like the idea of normalizing the fact that early labor, for the vast majority of us humans, it sucks, right? It's not a comfortable experience. And part of it is, how do you cope through it? So having this as an idea of that you're getting out of your head and into your body, right? You're getting music on, you're going with your partner. And the partner component to it has been, I think, also a huge thing that we were hoping would be good, but that actually has been even more impactful, because they are now having the ability to say, I can do something, right? Our slide deck, if you want to go to the next slide deck, it'll show, I think, an example. They're reading. So the partner's reading exactly what needs to be going on and is able to help them through that. And I think we both have seen a big impact from that, with partners feeling so much more included, instead of, here, you want me to take her home. She's in pain. I brought her here to you because she's not doing good, right? So now you're telling me I have to take her home, but you're not giving me anything to work with. And so I think this really does speak to that autonomy that we're looking for as far as empowering. And if they finish our walk and they get to the end of the walk and they're like, let's go eat some lunch, then they probably aren't in labor, right? Which is a validating, also the normal part of everybody up on labor and delivery telling you that this is normal, this is not, it doesn't feel normal until you actually are going through it. The next slide. So these are two of our patients that were willing to be on pictures and released to us. But the end on the right, the left-hand side, that's the end of our walk. You actually end, the last station is a breathing station at the sunflower field, and they either choose to come upstairs and see us, or they end up going home. Next slide.
And in here, this is some of our updated data that we've been able to decrease our early admission rate and decrease our NTSV rate. So that's been really exciting. We collect data of all the patients who are participating. And then we also have a survey to see kind of their experience in doing the early labor walk, if it went well. Next slide. And again, this is looking at it based on population, and we're seeing improvements, which is really great. Go to the next slide. Some things that we want to go to, and I saw some questions in the chat, is we want to create, and we actually created a great flyer that is in our clinic. So then patients can know, kind of expecting to do this early labor walk, that it's something they could be sent on. We were able to present our early labor walk at the National Conference of AWAN in June in 2025. Our goal is, and I saw the question, is this in multiple languages? So our goal is, we're doing a proposal right now. We're actually doing it tomorrow for Kaiser Salsac, where we're requesting to see, right now we just have a slide deck with all of our our early labor walks positioning, but what we would really like is to get videos made with voiceovers with like the top 5 languages. In the area that we support, South Sacramento is a very diverse area with multiple languages, and we feel like to really do it justice to support patients and also looking at that lens of equity would be to getting more languages involved. So right now we're doing a proposal to request to get funding from our hospital, and we're also looking to get videos created so then this early labor walk could be shared and implemented at other hospitals all over the region of the hospital that we work with of Kaiser. So that is something that we're going to be trying to get together and requesting. So hopefully that goes well. And then we're moving into, you want to talk?
Yeah, and we're working, we actually, obviously the side effect, when we talk about side effects, we usually are negative things. The side effect to the early labor walk seems to be supporting vaginal birth, shockingly enough, right? Physiologic movement and activities supporting spontaneous vaginal births. To date, we don't have June's data, but we've had through June, we had 40 humans have done the walk and 36 humans have had spontaneous uncomplicated vaginal births. So that right there kind of leads to, oh my goodness, the reason we started the early labor walk is mainly to manage and give that support of that early labor process and normalize that. But it certainly does seem like it is a great side effect to actually supporting a vaginal birth. So we are putting in for a research project to actually see the correlation between the early labor walk with movement and music. Does that lead to spontaneous vaginal birth? So more to come on that. But the big thing is normalizing, right? I see somebody making a comment in the chat. It is normalizing the process, right? And so much of it, if we can see other people doing it, we're modeling it. If we can hear about it, then it does become normal. And early labor is not a sprint. For the vast majority, it's an endurance event. So we really do have to kind of shift that. And that's kind of where we are for our walk.
Thank you.
Yeah.
Awesome. Thank you, Lexi and Spring. Thank you so much for this awesome presentation. I've been so looking forward to sharing this with everyone else. Thank you all for joining us. I'm sorry, but I'm not sorry that we don't have time for Q&A because we had such great information being shared by these hospital teams. But we are so excited to continue sharing some of these lessons. Our next session of the series is on August 25th, where we'll talk more a little bit about staff and leadership engagement. So more focused on what inpatient engagement can look like and extending that out into the community. If you have any more questions for the team, you can reach us at info@cmqcc.org, or if you're interested in learning more about being part of the Learning Initiative. So each of these hospitals have been part or are a part of the Learning Initiative currently. So a lot of this work has been integrated into this curriculum and vice versa. We're launching round 4 in the fall, and we're launching round 5 in winter. So come 2026, if you're interested in participating as a California hospital, please feel free to reach out to us. Or if you'd like to get connected to any of these presenting hospital teams, you can use this email as well. You know where to reach us and stay involved with CMQCC. Thank you so much for joining. We will be posting the webinar and the slides in the next couple of days, so stay tuned. And I believe Cherry posted the registration in the chat. So if you have any questions around that, feel free to reach out or register for the webinar. Thank you so much for joining. That's the end of our session today. We appreciate all of you and all the hard work that you're doing. Stay tuned, and we will see you guys next month.